A very warm welcome to you all to our UPMC public information event with a focus on ophthalmology. I'm Claire Phelan, Director of Access for the UPMC network and your host for the evening. The purpose of tonight is a public information session on eye health, diagnosis, available treatments and prevention of eye vision conditions. We have an excellent lineup for you this evening, with 4 of our consultant ophthalmologists who are currently delivering comprehensive and advanced treatments for eye and vision problems using the latest technologies and techniques. Each of our consultants are delivering this service in UPMC Whitfield Hospital in Waterford, UPMC Audheven Hospital in Kilkenny, and UPMC Kildare Hospital in Clane. You can learn more about our consultants and how to access these services on upmc.ie. Just moving to some housekeeping, you can submit any questions you may have via the Slido or chat. You'll see the green button that says Ask a Question. The consultant, with time permitting, will facilitate the Q&A at the end of each of their talks. So please get your questions in early. Our first speaker this evening is Mr. Tom Stumpf. Tonight's talk is titled, Can Doughnuts Cause Blindness? So without further ado, I'm going to hand over to Mr. Stumpf to deliver his talk.
Good evening, everyone, and welcome to this webinar. Tonight, I'm going to try to answer the question if donuts can cause blindness. This will involve a few stories, and I hope you find it interesting. Before talking about the subject, I just wanted to let you know a little bit about me. I started studying medicine at Southampton University 40 years ago. I developed an interest in eyes in my 4th year of medical school, and then pursued a training program in Bristol. I've been a consultant for 20 years, and most of that time I've practiced in Waterford and Kilkenny. And a lot has changed since 1986 in the medical world, but some things have stayed the same. And that's the way we manage patients. Generally speaking, this involves taking a history from a patient, examining the patients, ordering some investigations, making our diagnosis, and then planning our treatment. And the patients tend to be divided into various specialties depending on what the problem is. If you have an eye problem, you see an ophthalmologist. If you had a heart problem, you see a cardiologist. If you don't know what kind of problem you have, you probably end up with a GP. So the story this evening starts with a 56-year-old gentleman. This gentleman loved donuts. And when I say donuts, he did like donuts, but he also liked many other things, such as pizzas, burgers, kebabs, crisps, chocolates, biscuits, cakes, and so on and so forth. You get the gist. And not surprisingly, he, over many years, became overweight and has been a type 2 diabetic for over 10 years. He also has a bit of blood pressure and cholesterol, for which he's on a number of medications. I first met him about 5 years ago when he came to me with blurred vision. His visual acuity at the time was 618, which for those who don't understand or know what that is, it is below the driving standard. And when I examined his eyes, he was found to have cataracts and diabetic macular edema, a form of diabetic eye disease. This were the scans of the back of his eye. The retina shows multiple hemorrhages, and the macula is swollen due to edema caused by the diabetes. And this was one of the reasons he couldn't see properly. So in the last 5 years, I did his cataract operations in both eyes, and he's had 40 injections. And you might ask, why 40? Well, that's how many he's had so far, because every time you do an injection in the eye, it works, but it doesn't last. Like any drug, it wears off, and then you need another one, and another one, and so on. And in between, you also need a visit to the clinic to check how the treatment is progressing. And over the last 5 years or so, his vision has been fluctuating between 6 over 7.5 and 615, which is kind of borderline for driving. And he's been also seeing his GP for his diabetic treatment. He's trying to optimize his sugar control, monitor his blood pressure and cholesterol. Now he's been advised to lose weight and is considering starting Ozempic, which is one of the newer weight loss drugs. Unfortunately, this little story is not a fairy tale because he did not live happily ever after. Despite the right diagnosis and treatment, he has impaired vision. This is going to be a lifelong problem and therefore need lifelong treatment. And it is likely he's also going to get other diabetic complications, and these will have a marked effect on his life expectancy. He knows he has a problem. He also knows that this problem is curable through lifestyle measures. I've told him that, but he's unable to change his life in his current society that he's in. He just loves the donuts too much. And you might say, but why? Well, the human brain is wired to eat because if we don't eat, we will die. And like all mammals, our survival as a species depends on our ability to drink milk from birth. Now, milk is quite peculiar in its contents in that it has sugar in the form of lactose, which is a carbohydrate. It has protein, it has fat, it has salt, it has a number of other things as well. But in nature, in the natural environment, it is very rare to find this combination of ingredients. You can find them individually. Sometimes you can find them combined. For example, carbohydrates and proteins are found in beans, and protein and fat is found in the form of steak. But carbohydrates and fat are very rare in nature, unless, of course, you put them together yourself. And that's called cooking. And we humans have been cooking for thousands of years, and most of the food is delicious. However, companies or multinationals have in recent years figured out what kind of ingredients to put into this food that makes it last a long time on the shelf. It makes it nearly irresistible, so you can't stop eating it. That is in order for them to make massive profits on the back of it without much consideration for people's health. And where did this all come from? Well, to explain that, I'm going to go back a few hundred years to the cotton wool plantations in North America. Cotton wool has increased dramatically between the 1700s and the 1900s, and the cotton crop has the fiber which is used to making clothes and garments, but it also has cotton seeds. Now you need some of these seeds to grow new cotton plants, but there was an excess of these seeds and they just didn't know what to do with them until they figured out that you can use cotton seeds to make cotton seed oil. And at the time, houses were being lit using lamps, and these lamps used to have whale oil. So the whales were very grateful when they figured out that you can use cottonseed oil to light these lamps. And they also figured out that you can use it for cooking. Until, of course, mineral oil was discovered in Pennsylvania, and the demand for cottonseed oil plummeted. So the company Procter & Gamble realized that if you bubble hydrogen through this cotton seed oil, you can make a solid vegetable fat that resembles lard. And in the process, it generates lots of trans fats, and trans fats have since been found to be extremely damaging to health, something they didn't know at the time. The advantages of producing this artificial fat was that it has a very long shelf life and can be used in all sorts of cooking, from frying food to making biscuits and cakes and so on. And at the time, they were advocating the health benefits of vegetable oils, and they're even handing out free cookbooks. Now, the American Heart Association was established in 1924, and shortly afterwards, this multinational gave the American Heart Foundation an awful lot of money, and they're still donating lots of money to the American Heart Foundation. Now, around the same sort of time, there was a Russian scientist called Nikolai Anishkov, who decided to feed rabbits egg yolks, because egg yolks are very rich in cholesterol. And what he found is that these rabbits got heart disease, and he therefore concluded that cholesterol must cause heart disease. The problem is, in the nature, in the wild, rabbits don't eat egg yolks very often. So this is not a real comparison, unless you, of course, you're the Easter Bunny. And around the same sort of time, there was a Norwegian doctor who described a rare familial condition where people had very high and I mean very high cholesterol levels in the blood from a young age, and these people died prematurely from coronary heart disease. And this seemed to be contributing to heart disease and other things. The problem is cholesterol isn't all bad. Our bodies make cholesterol, and without cholesterol, we would die, we wouldn't live. So cholesterol is essential for life because it forms part of our cell membranes, and it's used to make various hormones that we use to in our bodies. So they then realized that not all cholesterol is the same. You have the good cholesterol, which is often referred to as HDL, and the bad cholesterol, the LDL. And what they figured out is that saturated fat seems to increase LDL. However, more recently, they found out that not all LDL is the same. You get large, buoyant LDL, which isn't that bad, and small, dense LDL, which isn't really that good because it gets oxidized within the blood vessel walls and contributes to arteriosclerosis. And the thing that leads to the production of this small, dense LDL is sugar. Now, in the English language, words often get mixed up. And the word fat can mean something called someone who is overweight. It refers to a chemical, which is a chain of carbons surrounded by hydrogens, which can be either saturated or unsaturated. And it refers to food, fatty acids, triglycerides, cholesterol, and also butter and lard and olive oil. So these are all fats, and the words often get interchanged. And the same is true for sugar. Now, the sugar that we put in our tea or have in spoons on the table is sucrose, which is a disaccharide between a bond between glucose and fructose. And it's actually the fructose that gives it the sweet taste. But sugar is also often referred to as what's going in your blood. So your blood sugar level should really be called your blood glucose level. And there are dozens of names within the processed food that are in effect a sugar, for example, high fructose corn syrup. Now, in order to prove that fat was bad, there was a scientist in America called Ancel Keys, and he published the 7-country study. And for this study, he looked at the dietary intake of 22 countries around the world, and he looked at their rates of heart disease and deaths from heart disease. And what he found that in countries like Japan, where fat consumption was very low, and I mean saturated fat consumption was low, they had a low incidence of heart disease. And in countries like America, where the consumption of saturated fat was very high, they had a high incidence of heart disease. And so in 1982, the American Heart Association and others generally put out advice to reduce fat consumption in an attempt to prevent cardiovascular disease. And they created this thing called the food pyramid, which many people have come across. And this became the foundation for dietary advice, not only in America, but in most of the Western world, and by now most of the world. The problem with this study was that although he published the results for 7 studies, he actually looked at 22, and some countries like France, they had a very high intake of saturated fat, but a very low incidence of heart disease. And that didn't fit the graph that Ancel Keys was publishing, so he left it out. The other thing was that if you look at dietary sugar consumption, well, it matches that of the fat consumption, because often in diet, fat and sugar in the ultra-processed food go together. Just think of our doughnuts again. And so in the advice, or in the attempt to reduce saturated fat consumption, if you take fat out of any food, it makes it rather unpalatable. And in order to make it palatable again, well, you have to add sugar. And you end up with labels like reduced fat or low fat or fat-free. And this is the basis for the ultra-processed food industry. So there's no doubt that sugar consumption has gone up markedly, 5-fold in the last 100 years. But our metabolic needs for humans hasn't really changed in the last 100 years. If anything, we're burning less calories now than we did 100 years ago, as technology has taken away a lot of the manual labor. So what we're doing is we're consuming these extra sugar, by effect, extra calories, and whatever the body doesn't need, it ends up being stored. And it can be stored in the liver and muscle for rapid access, and I usually use the analogy of a fridge, or it can be stored in the fat stores, and I use the analogy of a freezer. So when you consume more sugar than you need, initially you fill up the fridge, and when the fridge is full, you end up putting the rest in the freezer. The problem is when you actually need the sugar, well, you help yourself to the fridge because it takes too long to defrost the stuff out of the freezer. And that leads to raised blood sugar levels because the sugar in the blood cannot be converted to fat quick enough. So the blood sugar levels are high. And when it does get converted to fat, it gets stored. So it causes obesity. So recently, there have been nearly 500 million people affected by this diabetes, which constitutes nearly 10% of humanity. It is reaching epidemic proportions, and it doubles the risk of early death, and it doubles the healthcare costs of the affected people. And it's spreading throughout the whole world, so much so that these days overnutrition or obesity is a bigger problem than malnutrition or undernutrition. The problem is that once you have the diabetes and the obesity, well, then you get high blood pressure. And if you get diabetes, obesity, and high blood pressure, well, you end up with heart disease and strokes. You also end up with things like osteoporosis, arthritis, autoimmune conditions, irritable bowel syndrome, reflux, dementia, mental health problems, even cancer. And all these conditions have been linked to lifestyle issues, and in particular, bad nutrition. And they've now been kind of bundled together, and they're known as metabolic syndrome. And so how do you treat all these various conditions that are arising? Well, if you're diabetic, you take tablets or insulin. If you're high blood pressure, you take tablets. And if you've got high cholesterol, you take statins. And if you've got all those things, you've probably got an irregular heartbeat, or so you take blood thinners. And after taking all these tablets, you end up taking antacids because you get indigestion, and you take antidepressants because you become depressed. And right at the bottom, it says, well, eat less and move more, diet and exercise. But that's not the main driver to treating these conditions. And to me, this doesn't really make sense. And to quote Archbishop Desmond Tutu, there comes a point where we need to stop just pulling people out of the river. We need to go upstream and find out why they're falling in the first place. Now, this brings us back to something called smoking. 100 years ago, people used to think smoking was healthy for you. So much so that during the last influenza pandemic in 1918 or thereabouts, people used to smoke to try to prevent catching the flu. Obviously, in the last 100 years, we've now realized that smoking is actually not good for your health. As a matter of fact, it's terrible for your health. But it's taken 100 years to prove not only that cigarettes are bad, but that people shouldn't smoke. And in a way, a similar thing is happening with the food industry and the pharmaceutical industry. I'm not saying drugs are bad. They do what they're meant to do, but they don't solve the underlying problem. And when it comes to food, things like sugar are generally regarded as safe because people don't look far enough into the future to look at the consequences of a high sugar diet. So my nutritional advice would be, well, simple. Eat food, mostly plants, and not too much. Make sure you have lots of vegetables, fruits, salads, seeds, nuts, and lots of beans. And limit the intake of sugar, flour, and vegetable oils. The vegetable oils is slightly controversial because things like extra virgin olive oil is very healthy. Whereas some of the seed oils, some people would suggest that they may not be quite as safe as we think. Also important is sleep, 8 hours a day, exercise, make sure the pulse goes up a bit, and manage the stress. Unfortunately, I don't have time to go into the evidence for all of these things this evening, but needless to say, I'm just going to tell you one little story, and it's about the blue zones. Now, for those of you who don't know what the blue zones are, there's about 5 places around the world that have the highest proportion of centenarians. These are people reaching the age of 100. Now, they're not 100 in a nursing home in a wheelchair drooling, but they're out and about, and they're playing with grandkids, and they're playing cards, and they play golf. And the question is, how do they get to 100 in reasonably good nick? whereas people in most of the rest of the world end up dying by the age of 80 with chronic disease. And part of it, by no means everything, has to do with what they eat. And just to summarize that, imagine a farmer in Sardinia wakes up in the morning and realizes he has no bread. He walks down the hill to his local bakery where they've made sourdough bread using stone ground whole flour meal. And then he bumps into his friends in the village square. They play a bit of cards. They might have a cup of coffee or a glass of wine, and then he walks back up the hill. Now imagine a farmer waking up in Ireland. He realizes he's got no bread. He gets into his Jeep, drives to the local petrol station, buys a loaf of sliced pan, might grab a can of Coke, sees nobody, and drives home again. They've both gone out to buy bread, but they've gone about it very different ways. And it's that is very important to your health. So to finish off, modern medicine has evolved to diagnose and treat disease. It's all about what test can we do and what treatment can we recommend. We very rarely ask why. Why is there this disease? And more importantly, if we know what causes the disease, what can we do to prevent it, or even better, reverse the disease? Now, this isn't easy and it takes time. And it usually fails because it requires a whole of society change. These changes have been initiated in some countries like Chile and the Scandinavian countries, but it's got a long way to go and it's nowhere near enough to what we need to do. The other thing that needs to change is our knowledge of what food does to us and educating not only doctors, but the whole population. And the old way of going about teaching medical students, there is not enough emphasis on prevention of disease. And when it comes to different specialities, there isn't enough about the holistic approach. What I mean by that, if somebody comes to me with an eye problem, they're a patient and they have other problems, and we need to look at it all together. So to answer the question, can donuts cause blindness? Well, yes, they can if you eat too many of them. And this isn't just me saying it. This is actually being published in the Annals of Internal Medicine, where there have been cases reported of people who've gone blind on a junk food diet. For anybody who's interested in more information, there's a Netflix series called Live to 100, The Secret of the Blue Zones. And there's a podcast series called Zoe's Science and Nutrition by Professor Tim Spector, which has got a wealth of information. Thank you very much for listening. And please do not hesitate to ask me any questions either this evening on the webinar. Alternatively, you can drop me an email. Thank you.
Thank you, Mr. Stumpf. That was absolutely excellent. We actually have a couple of questions from the members of the public, so I'm just going to read them to you. If sugar is so bad for our health and the main culprit in the development of type 2 diabetes, why don't governments introduce a sugar tax as they did with cigarettes?
Good evening, Claire, and everybody who's listened this evening. Thank you for joining us. Very interesting question. Well, some places have introduced a sugar tax. There is a limited sugar tax on some beverages in the UK, and they've tried to do something similar in some places in California. The problem was when they tried to expand it within California and beyond that in the United States, the various food companies met with various state governors and kind of said, look, if you pursue this agenda of expanding the sugar tax beyond sugar drinks, we're going to have to lobby the various voters to introduce legislation so that you can only pass laws with a 2/3 majority of your cohort of government, which makes it nearly impossible to pass any laws. So the governors had no choice but to backtrack and not introduce. So the food lobby as a whole is extremely powerful, has extreme amount of resources at its disposal that will prevent a lot of laws restricting sugars and taxes being passed in governments, particularly in America. But I suspect something similar will is happening in Europe as well, because various committees meet at intervals to try to discuss national policy and tax policy, and they will have lobbyists from the food industry, and they always come out with this comment, well, the evidence isn't really that strong, and the food industry also sponsor research to kind of muddy the water and introduce doubt into people, and therefore they don't make progress. I mean, just look how long it took to introduce taxes on cigarettes.
Mm,
Even though everybody needs to eat, but not everybody needs to smoke. As a matter of fact, nobody needs to smoke.
mm. Okay. And just one more. If you had the power to change one thing to prevent diabetes, what would it be?
That's a difficult question to answer because diabetes is multifactorial. Um, I think the tax route would be a good way, but not just taxing sugars, but taxing anything that's ultra processed food, from things on supermarket shelves to kind of takeaways. And various countries around the world, like in Chile and in Scandinavia, they've introduced this kind of system of scoring different food products, and the higher they score on the health front, they should get subsidized, and the lower they score on the health front, they should be taxed. And the tax from the so-called ultra processed foods should then be used to subsidize the healthy foods. So you'd go into a supermarket, and if you wanted to buy a lettuce or a broccoli or banana, you buy it for next to nothing. So it's so heavily subsidized that it's practically free. Whereas you then go and buy a donut or a Kit Kat, and it's costing you 2 or 3 times of what it cost before. So you can still buy the donut, but it's a bit like cigarettes. It becomes very expensive and people get priced out of the market. And what they should have is lots of healthy nutrition at very low prices that they can easily afford, because the profit margin on ultra processed food is huge. And the profit margin on carrots is very low. So we need to subsidize healthy food, basically.
Okay, Mr. Stumpf, I don't see any further questions coming in there, so thank you so much. I hope we've answered those questions that have been raised. Oh, wait, now just one more coming through. If you have the time, Mr. Stumpf.
Yeah, no problem.
What are the differences between seed oils, which are bad, and olive oil, which is good?
So olive oil is extracted from olives. It's been done for thousands of years. I mean, extra virgin olive oil was the Romans used to have it. Now they didn't always need to eat it, but they used to bathe in it as well. But
Hmm.
you basically get olives, you crush them up, and what you get is extra virgin olive oil. It's a very artisanal, simple process. When it comes to seed oils, they need to be heated and crushed, and then you get an oil out of them. And this oil is not only cloudy, but it has a slightly offensive smell to it. So it goes through various industrial processes where you add and remove chemicals to what would say purify the oil. And there are some question marks over this industrial process that you do to the seed oils, whether that has any damaging effects on health. And I'm always very wary of industrial processes because of what I said in my talk earlier. They used to think cottonseed oil was healthy, and then they decided to bubble hydrogen through it, and then they realized that they could make something that resembles lard. And then what happens is they went around using Crisco all around America and the world, and then they discovered trans fats and realized that actually this is causing awful lot of problems. So they went for decades not knowing what trans fats were and realizing people were getting sicker. And I just intuitively a bit cautious about anything that involves an industrial process,
Hmm.
even though there is evidence that obviously polyunsaturated fatty acids are good for your health. And I don't doubt that. I just wonder about the chemical processing of these polyunsaturated fats.
Okay, Mr. Stumpf, just one more question. So, because it's moving kind of away from the nutritional side of questions, are corrective lenses available to slow down dry macular degeneration?
Um, there is a thought that blue light increases the incidence or the severity or the progression of macular degeneration. And that's to do with the fact that the wavelength of blue light is nearer the ultraviolet end of the spectrum. And there's some thought that it may be cytotoxic, it damages RPE cells and photoreceptors. I know for a fact that various people have used yellow lenses in their glasses, and I know for a fact some of the intraocular lens manufacturers that produce lenses that we use in cataract surgery have put a yellow filter in them to cut out these blue lights. But I think the actual evidence that blue light and these lenses actually prevent the progression of macular degeneration is still a little bit uncertain. I think it requires more research, and I think the one needs to think about the underlying physiology. And whilst the light and free radicals could contribute to macular degeneration, I believe you're better off by preventing it in other factors, which is to provide lots of antioxidants for retinal cells so that if there is any damage from the light, it can be easily be repaired.
Okay, that's brilliant. Thank you, Mr. Stumpf, for your talk this evening. We're now going to move to our second speaker, Mr. Gareth Higgins. Tonight's talk is titled Skin Cancer Around the Eye, and key themes relate to risks, detection, and prevention of periocular skin cancer. So over to you, Mr. Higgins.
Hello, my name is Gareth Higgins. I'm an ophthalmic surgeon with a special interest in oculoplastic surgery and corneal transplant. I work at UPMC Whitfield, Otaven Hospital Kilkenny, and I'm also working at University Hospital Waterford. And I just wanted to talk briefly about skin cancer around the eyes. Why the skin around your eyes matters. Well, first of all, your skin around your eyes is your thinnest skin, which makes it more vulnerable to sunlight over time. There's a high sunlight exposure, so your face obviously receives more UV exposure than almost any other part of the body. Hats help, but you can't fully protect your lower lids. And sunscreen in the eyes, that can be painful, so people tend to avoid this. The eyes are delicate structures, so if you are removing skin cancers or growths, there are obviously some structures that you need to protect. The main types of skin cancer around the eye, the most common is a thing called basal cell carcinoma. Basal cell carcinoma occurs in about 70 to 80% of skin cancers, and thankfully, these are slow growing and occur usually over months to years. They rarely, though it has been described, they rarely spread to other parts of the body and are highly treatable with surgery. Squamous cell carcinoma, they grow more quickly. They have a small risk of spreading to the rest of the body, but are also very treatable when treated early. And then melanoma is the more serious type, which is less common, less than 5%. That can appear as a changing dark spot on your eyelid or face. Any new pigmented lesion near your eye should be checked promptly by either your GP, dermatologist, or an ophthalmologist with a special interest. What should you look for? Well, first of all, a lump or a bump that won't go away. They're often pearly looking or waxy looking, sometimes with unusual blood vessels on the surface. If you have a sore or a scab that doesn't heal within a few weeks, keeps bleeding, crusting over, and then bleeding again, this is something that perhaps you should have looked at. Loss of eyelashes in one area, and I will show some examples. So if you're losing eyelashes in an area of your eyelid, then that can be a sign that there's an underlying skin cancer. A change in the shape of your eyelid, a notch, a thickening, or a distortion of the lid. And lastly, if you have a new or changing dark spot, particularly one that is growing, has uneven color or borders. I'll give some examples. Here you see a recurrent scabbing over lesion that is occurring in the right upper eyelid. You can see the edges have a rolled edge, and that's typical of a basal cell carcinoma. And as you can see here, prior to surgery, I've marked out the kind of borders that we need to take to fully excise a lesion like this. Here's another example. This is in the medial aspect of the eye, or on the side toward the nose, and this is a very typical location. Here's one that's a bit less typical. It's got irregular borders, and it doesn't have that overlying ulceration or scab formation. Here's another example. Now, in this example, you can see there are lashes on the eyelid further over to the right of this picture, but where the lesion is, there are no lashes, which is an early sign. You can also see some thickening, and then the indent is an example of ulceration. This is a squamous cell carcinoma. These tend to be more aggressive, more irregular in shape and size. So you can see this one was quite rapidly growing. This is in the left cheek, which isn't immediately obvious from the picture. This is a case that I did recently. As you can see from this, there is a sheen which indicates that it's slightly raised. The pigmentation is irregular. This did indeed turn out to be a melanoma. This case is a large lentigo maligna, which is, despite its name, not a melanoma and not a malignancy, but can be a pre-melanoma. There were some features in the center of this lesion that did amount to what's called melanoma in situ. In other words, melanoma that hasn't invaded the deeper layers. And therefore, you can see I've marked out this area for excision and then subsequent repair. Where did these cancers occur? Well, the majority, as you'd expect from the sunlight exposure, occur in the lower eyelid. So these are my figures from University Hospital Waterford over a 3-year period. And as you can see, the majority occurred in the lower eyelid, followed by the inner corner, which we saw in the previous picture, on the nose side of the eyes, and then followed by the cheek, the brow, upper eyelid, which tends to be shaded by the brow, and then the outer corner. So that fits with what you would expect for the sunlight exposure. What happens if you need treatment? Well, your GP or dermatologist usually would refer to somebody like me. I examine the lesion, often with a magnifying glass, and can try to confirm the diagnosis clinically or to take a biopsy. We plan the best approach. Now, I tend to tailor my approach based on the complexity, size, and location of the lesion involved. Most of the time, you can have it done as a day case where you go home the same day after a local anesthetic. When we do remove the skin tumor, it's carefully removed, as you saw from my marking, with a margin of healthy tissue around it. In some cases, the tissue will be sent to the lab and we wait on the reconstruction until we know that the margins are clear, and I'll outline that in a little while. Reconstruction then is performed either with skin grafting or more commonly with rotation of local skin flaps. And then you will be followed up long term to check, initially to check on the wound and check everything is healing properly, and then later on to monitor for recurrences. Who's treating you? Why am I treating you? Well, I'm an oculoplastic surgeon. An oculoplastic surgeon is an ophthalmic surgeon who has completed advanced training in reconstructive surgery of the eyelids, the orbit, and the lacrimal system, and the periocular skin. This is a dual expertise in both eye surgery and plastic surgery in the upper face and around the eye, making oculoplastics quite a specialized area. So I do reconstruction of eyelids. Sometimes it's for things like trauma, for just ptosis, which is drooping of the eyelid for whatever reason. Sometimes people have aging problems where the eye turns out in the form of an ectropion or in the form of an entropion. But in this talk, we're talking about my work, reconstruction of the eyelid following excision of skin cancers around the eye. I also do certain orbital tumors, thyroid eye disease, and blocked tear ducts. So there are 3 approaches I take depending on the size, the type, and the location of the skin cancer. So if it's a very simple one with a relatively straightforward repair, I may remove the cancer and repair it in the same day. Obviously, if the histology later on shows that that it is not clear, we will have to go back and take further biopsies. If it is a bit more involved, but relatively straightforward to reconstruct, then I will do a staged procedure where I will remove the tumor on day 1 and put a pad on the eye and defer the reconstruction until the following day when the pathologist calls me to tell me whether I have cleared the tumor or whether there are still cells in the peripheral aspects of my sample. And for more involved cases or cases where more extensive reconstruction is involved, or if in cases where the margins of the growth are not that clear, I will refer to what's called a Mohs surgeon or a Mohs specialist. This is a specialized dermatologist usually who will remove the cancer layer by layer and then examine it in the microscope, confirm clearance in each layer before he sends me the defect to reconstruct at a later date, usually the following day. This, in an ideal world, all cases will be done like this because it has the highest cure rate for the most complex cases. So, as I said, Monday morning, we remove the tumor. The following day, the pathologist will call me in the morning, let me know that the tumor is clear, and then we can reconstruct happily, knowing we won't have to undo this. The joint case, there's, as I said, Mohs surgery. It's a technique where the cancer is removed one thin layer at a time. Then the Mohs surgeon will examine it under the microscope there and then, and repeat until no cancer remains. It means he can follow every little root of the skin cancer and make sure everything is clear. The Mohs surgeon that I work with is in St. James's Hospital for my public patients and in the Bon Secours Hospital in Cork for my private patients. So in the public hospital, the surgery takes place on a Tuesday where the patient goes for a day case. Their skin cancer is removed. The wound is dressed overnight, and the following day at University Hospital Waterford, they have the reconstruction done. In UPMC, I have an arrangement with the Mohs surgeon in the Bon Secours in Cork who does the excision, and I do the reconstruction the following day. Our results, well, we've recently audited 3 years of results in my public job, and I had done 380 cases over a period of 3 years. We had 95% clear margins at first surgery, so only 5% required any re-excision. And overall, over that period, we had a 1.1% recurrence, which is approximately a quarter of what the international published figures would be. We are currently doing well over 100 cases a year, and if I factor in my private practice, this amounts to something like 180 to 200 cases a year out of a national total of 650 to 700 periocular non-melanoma skin cancers per year. So we're performing quite a chunk of the national cases. As I mentioned, the vast majority of skin cancers around the eye are completely curable with surgery. Over half of the patients need only straightforward stitching, and larger defects can be repaired with good functional and cosmetic results using local skin flaps. Reconstruction techniques. Well, I'll just show some various sketch diagrams. Please forgive my art. So one common area is the medial canthus in the nose side of the eye. And as you can see, you have to take an extra margin, which can create a relatively large defect. A common flap I use is borrowing the excess skin that you have between your eyes to rotate in the form of a flap into the defect. If you have a smaller area in that area, another flap becomes possible, which is a bilobed flap, which borrows the skin that's a little bit further down, more toward the eye level of the in between the nose, called a bilobed flap. And here we see the lobes rotated into place. If it's further down in the cheek, another common area, an option is to do an advancement flap. All of these flaps tend to have excellent long-term cosmetic results. As you can see, we can bring in a tongue of skin from the loose skin of your cheek to reconstruct, and that once the sutures are removed and everything heals, it tends to have a very good cosmetic effect. Sometimes we have very extensive tumors that can involve some or even all of the lower lid. In this case, it gets a bit more technical, and we have to reconstruct the eyelid from other materials from the body. Commonly, if you had a total lower lid defect, I may borrow the cartilage, because we have the back part of the eyelid is formed by cartilage and the front part is formed by muscle and skin. So often what I will do is I will turn the upper lid over and borrow the spare cartilage from this and suture it, as you can see in the top diagram, to replace the cartilage of your eyelid. I then use a cheek rotation flap to rotate skin and muscle into that area, and that gives you a new eyelid and tends to have a very good appearance once the dust has settled and everything is healed. But obviously we want to avoid these kind of surgeries, and we want to protect your skin and stop it from happening in the first place. I don't think I'm the first person who has said to wear sunscreen. A lot of moisturizers that you can get in the chemist will have factor 50 in the moisturizer, and it's probably not a bad idea to get into the habit, even on cloudy days, of wearing moisturizers with a sun protection or sunscreen on a daily basis, even when you think that you're not at risk. Sunglasses are very important when you're out in the sun, out and exposed to sunlight, because you're not going to be able to protect your eyelids with sunblock. In your habits, you can avoid peak sun hours, so perhaps stay in the shade when the sun is strongest in the middle part of the day. Regular skin checks, so don't ignore any lesions that you're concerned about. If you catch it early, these things are often much more easy to treat. So the key takeaways from today's message: skin cancer around the eyes is common, but it's highly treatable. So, if you catch it early, then the job is much easier. The lower eyelid is the most frequent site. You should protect this from the sun wearing sunglasses or a hat. Watch out for lumps, non-healing sores, lash loss, or eyelid changes. If you're in doubt, you should see your GP or a dermatologist. Early detection, as I mentioned, makes the treatment much simpler. Most patients only need a day case procedure under local anesthetic. So thank you very much for your attention. I hope this talk was useful to you.
That's absolutely brilliant, Mr. Higgins. Thank you so much for that. We have a couple of questions that have come through. So I'm going to start with the first one. Does skin cancer around the eye always only need surgery, or might I need chemotherapy or radiotherapy as well? Thanks
very much for that question. The short answer is mostly. Really, thankfully, most skin cancers are basal cell carcinoma, which tends to be the less aggressive variety, doesn't tend to metastasize, and generally doesn't need anything more than surgery as long as you've cleared the margins. Squamous cell carcinoma, which I mentioned, that is an in-between one. So that sometimes can cause secondaries. So very occasionally I'll get a histology back that it's a high-grade squamous cell carcinoma. And thankfully I have access to multidisciplinary team meetings where we can chat among radiotherapy, radiation oncology, the histopathologists and various surgeons covering these areas, and we can come to a consensus opinion. And sometimes we do recommend radiotherapy, usually around about 6 weeks later in that sort of scenario. And then obviously melanoma is the one that that's a bit more serious, and very often that is managed as a sort of a multi-system disease because it has such a tendency to metastasize. So the short answer for most non-melanoma skin cancers, surgery is all that's required, but it's really, really vital that you clear the margins.
Okay. We move to the second question. I'm worried that surgery near my eye might affect my vision or the way my eyelid looks afterwards. How do you decide which reconstruction technique to use, and what can patients realistically expect?
Thank you again. So really, it's a mixed bag. Really, it depends what the extent of the tumor excision is and what the reconstruction is. So I would say in my hands, most cases have a really long-term of a very, very good cosmetic outcome without too much impact on the eye. In fact, I saw somebody just an hour ago, and I actually didn't realize until I got chatting to till I was chatting to him that I'd done a complete reconstruction of his entire lower eyelid from scratch, having had the whole thing removed for a tumor. And it wasn't obvious to me, even though I'd actually done the reconstruction until I checked my notes. So
fantastic.
in short, most people get a good outcome, in fairness.
Yeah. I think we'll just take one more question. If I notice a small lump near my eye that's been there for a few months, but it's not causing any pain or problems. Should I still get it checked, or is it only worth worrying about if it's growing?
Well, the thing about skin cancers is by and large they're painless. If it's an inflammatory lump, or like a chalazion or a little cyst, sometimes they are painful, but generally tumors are not painful. It's a feature of cancer that these skin tumors are generally painless. They do, if there is ulceration, that's certainly a sign that it needs to be looked at. There's lots of benign lumps that can be there, but really, it's really for a specialist to determine whether a lump is sinister or not, because very often something that is thought to be benign might not be, something that's thought to be serious, it might not be so serious. So the short answer is it's hard to tell really unless you have a look at it.
Okay, one more is after coming in, so I think we'll take the time to do it if that's okay. When wearing sunscreen during the winter, will you still get enough vitamin D?
Well, I mean, I think, look, I think you get enough during the summer. I think with the best will in the world, we're not going to protect us from sunlight adequately anyway. I think Irish people, certainly with complexion like my own, I think there's no shortage of vitamin D. Certainly in our climate, for people who are from overseas with more melanin, vitamin D deficiency is an issue. I don't think anyone's going to be getting rickets in Ireland if they're having a normal use of sunscreen, to be short.
Okay, that's brilliant. Thank you so much, Mr. Higgins, for taking the time to do those questions with us. I'm now going to move to our third speaker for the evening, Ms. Virag Varga. Tonight's talk is titled Designing Comfort, Rethinking Chronic Eye Disease Management. Key themes this evening relate to living well with chronic eye conditions and comfort-focused care strategies. So over to you, Ms. Varga.
So good evening, and thank you for the opportunity to give this talk. My name is Virag Varga. I'm a glaucoma and cataract surgeon. I work with the Institute of Eye Surgery at the Cork location, and I perform my operations at UPMC Whitfield Hospital. So my talk today is about designing comfort and rethinking chronic eye disease management. Glaucoma is a lifelong condition, and for most patients, treatment begins with eye drops. They are effective and they have protected visions for decades. However, over time, treatment can become more complex, more bottles, more dosing, and sometimes increasing eye surface irritation. So the question is not whether drops work or not, they clearly do. The question is whether long-term management can remain both effective and sustainable. Glaucoma is a chronic disease of the optic nerve, and in most cases there is a strong genetic component. The optic nerve gradually loses nerve fibers over time, and this leads to permanent visual field loss. Once the damage occurs, we cannot reverse it, and at present the only proven way to treat glaucoma is to lower the eye pressure. Importantly, we are not treating a number, we are treating a patient, and we are reducing risk. And the rule of thumb is that the more advanced the disease, the lower we typically aim for the eye pressure to be, because the nerve has less reserve. So imagine your eye like a sink. There is a continuous inflow of fluid and there is a continuous outflow of fluid, and the water level in the sink is by the balance of the two. So if the production exceeds the drainage facility, the pressure, the water level rises. Glaucoma drops work on both ends. They can either reduce the fluid production, turning down the tap, or they can improve the drainage facilities, widening the drain, increasing the outflow. The major drug classes developed for glaucoma are around for many, many years. Most of the drugs came out in the last century. The only glaucoma medication that has come out recently is still not widely used in glaucoma practices. While the delivery systems have greatly improved, the core biological mechanisms have remained largely the same. So eye drops have side effects. Every type of eye drop has very typical potential side effects. So when a patient with these side effects comes to the office, we can tell by the time they come through the door what drops they are on. Prostaglandin analogs are very effective and are often used first line. However, they can cause redness, iris pigmentation changes, eyelash growth, and over time, there are subtle changes around the eyelids due to the atrophy of the periorbital fat, which makes the eyes sunken in. These changes are usually cosmetic, but they are real and they can be noticeable. Alpha agonists like brimonidine, they can cause allergic type reactions. In some patients, this intolerance can develop months after starting, sometimes after 6 to 8 months of the drop actually working. And it's a real disappointment when you have to stop it for a side effect similarly seen to this on this picture. Topical carbonic anhydrase inhibitors may cause burning, metallic taste, and occasionally contact dermatitis on the eyelids. When multiple drops are layered over years, the cumulative exposure of the ocular surface increases. Many glaucoma drops contain a preservative called benzalkonium chloride or BAC. BAC maintains the sterility in multi-dose bottles and improves drug penetration by loosening the tight junctions on the corneal surface, basically loosening up the cells, increasing the gaps between them. This increases absorption, but it also makes the drop sting. So this is why we see that usually moving to a preservative-free formulation is better tolerated by patients. BAC is a surfactant. Basically, it's a detergent-like molecule. With repeated daily exposure over many years, particularly when several preserved drops are used at the same time, we see tear film instability and chronic low-grade inflammation. The effect is cumulative. It is dose and exposure dependent. The issue is not that the preservatives are inherently harmful, but that on a long-term multi-drop therapy can increase surface burden. Preservative-free drop options can eliminate BAC exposure. They are delivered either in single-dose units, which are to be thrown away after administering the drop, or some of them have specialized multi-dose bottles with a filtration system that doesn't allow sucking back contaminated fluid or contaminated air into the bottle. It's a very unique and very smart technology. However, these bottles are quite clumsy. The end bit is quite thick and it's quite hard to manage for people with rheumatoid conditions, mobility issues. So patients on several medications, preservative-free options can significantly improve comfort and surface stability. However, not every medication is available in a preservative-free form. There are formulation challenges, stability considerations, and also cost factors. Preservative-free drops reduce irritation, but it does not reduce the complexity of the treatment. So there is a laser treatment available for glaucoma, which has been around good 10 years now. It's called selective laser trabeculoplasty, and it's performed on an outpatient basis on a slit lamp mounted laser with a contact lens placed on the eye. It literally has zero side effects. It stimulates the eye's natural drainage system. It does not create any new holes in the drainage. It kind of rebuilds the tissue and enhances existing outflow. SLT can lower the eye pressure by about 20% in the best responders, but it may not reduce pressure for everyone, and it may not reduce pressure as dramatically as combining multiple eye drops. One thing that's worth mentioning is between the laser treatment and the drops, the diurnal IOP curves, the level of pressure during the days very much depends on the dosing of the drops. And with SLT, it works all the time. So we may not achieve as low pressures with an SLT laser than with adding on multiple eye drops, but the effect is continuous and there are not so many highs and lows during the day. Reducing large pressure fluctuations is beneficial to the optic nerve over time. And the effect of SLT can diminish over the years. And as I said, not everyone responds the same way. The mechanism of action is different to drops and sometimes at different matters. So what else is out there? Minimally invasive glaucoma surgery, or nicknamed MIGS, refers to low-risk procedures usually performed with microimplants that is placed into the drainage system of the eye. They enhance the natural outflow. They scaffold the natural outflow, so it's not suitable for eyes where the natural outflow has been severely damaged. These procedures are often performed at the time of cataract surgery. However, they can also be performed as standalone procedures in suitable patients. The aim is moderate pressure reduction and mainly reducing the drop burden and improving quality of life. They are not designed for very advanced disease requiring very low pressures, but for many patients with mild to moderate glaucoma, to provide the balance between safety and reduced medication dependence, it's an important factor in quality of life. The safety profile is significantly more favorable compared to traditional old school glaucoma surgery. It's also a very good solution for patients who are allergic to eye drops or don't tolerate them very well, because this procedure can be added in about 5 minutes at the end of a cataract operation, or even in eyes that had cataract before. And in the future, the number of drops that they have to be using is going to be significantly less. So obviously, not every patient needs glaucoma surgery, but alternatives should be considered if you require multiple drops. If you experience eye surface irritation, if adherence is difficult, or if you are planning cataract surgery, or if the disease progresses despite medication, then it's definitely worth considering. Glaucoma management today can be very individualized, and the strategy should reflect both the disease stage and the lifestyle. So when very low pressures are required postoperatively, we still turn to what we call filtration surgery. It's called filtration surgery because it filters the fluid from the inside of the eye to the outside, kind of bypassing the natural drainage mechanisms. The gold standard for this procedure was trabeculectomy, but as it was a technically difficult operation with very high risk and very slow recovery, it was always left as an absolute last resort to turn to when patients had significant visual field loss, potentially threatening their ability to drive or their ability to be independent. But it's not ideal to leave surgery for such a late stage. Although trabeculectomy is highly effective and can achieve very low pressures, and its use is still essential in advanced disease, it requires very close follow-up and, as I said, a very high complication profile, including the pressure going too low and the pressure being variable. PreserFlow is a microshunt that has been developed and implemented in the last few years, and it basically revolutionized glaucoma filtration surgery. It's designed to provide a controlled flow with giving almost as low pressures as trabeculectomy. The pressure behavior can be more predictable in the early postoperative period, and as I said, maybe it doesn't reach as low pressures as trabeculectomy, but because the safety profile is much better, the operations can be planned very early and the recovery is much quicker, and patients are happier to undergo a procedure like this than a much bigger operation like a trabeculectomy. Filtration operations are very powerful tools, and we still need to use them when the disease severity requires them. So glaucoma treatment is long-term. The long-term treatment needs to be sustainable. If therapy becomes uncomfortable, complicated, intrusive, that really matters. Modern glaucoma care includes eye drops, preservative-free options, laser, minimally invasive surgery, filtration surgery, and an endless number of combination of these. Treatment should be planned around your lifestyle and not the other way around. If you are struggling with your eye drops, it's reasonable to ask your doctor whether alternatives are appropriate. Meanwhile, we want to preserve sight. By all means, we want to minimize risk of procedures and reduce any unnecessary burden. Okay, that's it.
Thank you, Ms. Varga, for that presentation. We have a couple of questions that have come through, so I'm just going to put them to you now. When do you know that it's time to offer glaucoma surgery instead of drops?
Hi. Thank you for the questions. So basically, we offer glaucoma surgery for those patients who progress, whose visual fields and optic nerve scans are visibly getting worse. We offer surgery to those patients who present with advanced damage at a young age, and we know that we have another 30, 40, 50 years to plan for. We definitely offer surgery to patients who are intolerant to drops, and there is no other way to lower their eye pressure. But with the presence of minimally invasive glaucoma surgery and with the new devices in filtration surgery with less complications, we can offer surgery to those patients who are preparing for cataract surgery as an add-on. So no patient with glaucoma is exempt. Everybody can be offered surgery at some stage of their journey.
Okay, so sticking with glaucoma surgery, how long does the recovery take and how long will I be out of action?
So it depends on what procedure you had. So if you have a minimally invasive stent, a hydrus or an eye stent, the recovery is basically as quick as after cataract surgery. So you might be up and driving in a couple of days after surgery. Full wound healing is 4 weeks. You can return to your gym, swimming, whatever you like.
Yeah.
After filtration surgery, I say it's usually about 2 weeks till you forget about it, you had it, because that's how long the stitches are irritating. And the full recovery from the surgery is about a month or 6 weeks. But you can return to work and to your activities after, let's say, a week or a couple of weeks.
Okay, very good. So we have a patient here who's post-cataract surgery. So they have a blur sensation post-surgery, and it's not unlike having a partial cataract still present. I find bright lights very disturbing and I'm nervous driving at night, even though I don't need to wear glasses now. I am trying to source yellow glasses. So please give advice.
Absolutely, yes. So first of all, I would like to give some reassurance that it's highly unlikely that any of your cataract was left behind, because that's usually quite drastic. It comes with a lot of inflammation, soreness, not just a little bit of blurring. So if you still have a little bit of blur, it might be that you might have a little bit of refractive error. You might need glasses full time, but maybe a little bit for night driving. It might be an eye surface issue. And it might be that you are developing a little bit of scar tissue behind the lens implant, which is, this scar tissue is part of your old natural lens. And it's very common that it thickens up. It happens in 1 in 10 at least, and that can be very easily sorted with a laser treatment in the eye clinics. So I would definitely have it checked out, because I'm 99% sure that there is some sort of solution. Yellow glasses, they are good for night driving because they increase contrast sensitivity.
Okay, I hope we've given some reassurances there. And maybe just one more question. Is there a risk of adhesions and consequently worsening glaucoma after therapeutic surgery is performed to correct the original glaucoma?
It sounds like an expert level question. So this gentleman or lady or gentleman may have gone through a procedure themselves. So one of the main risks and consequences of glaucoma surgery is adhesions. But we are using techniques, medications, etc., to modulate the wound healing so that we don't get adhesions. There are a certain number of cases where glaucoma surgery fails and eventually closes down, sticks down. But if the patients are rarely worse off than before surgery. And if there is any worsening in the eye, that's usually to the glaucoma itself, not the scarring or not the surgery itself. So we always measure up risks against benefits, and we try to keep and we always try to keep it safe to avoid ending up worse than what the patient came in with.
Okay, Ms. Varga, that's excellent. Thank you so much. We've no further questions for you this evening. I'm now going to hand over to our final speaker this evening, Dr. Macchi. Tonight's talk is titled Protect Your Sight. Simple signs you shouldn't ignore, and key themes are early warning signs of serious eye issues and when to seek care. So over to you, Dr. Macchi.
Good evening, everyone, and thanks for joining. I'm Iacopo Macchi, a consultant eye surgeon and a retinal specialist. So today I would like to talk to you about the most common symptoms that some of you may have already experienced that could indicate a problem with the retina in the back of the eye, and that everyone should know so as to understand when to seek immediate medical attention. In fact, when it comes to retinal problems, timing is crucial, and early diagnosis and treatment are essential to preserve vision. So to begin, a very brief background on the structure of the eye. So you have to imagine the eye as a cavity filled with a gel-like substance called the vitreous. So the vitreous is composed almost entirely of water and helps support the eye and maintain its shape. It is basically attached to the retina, which is the innermost layer of the eye in the back of the eye. The retina is basically the neurosensory layer of the eye that converts light stimuli into messages that are then sent to the brain and converted into images. So the first and most common symptoms are floaters. Many of you might have already heard of floaters. So floaters are small specks or cobweb-like shapes or little shadows that drift across your field of vision. They're usually more noticeable when looking at a bright, plain background, like the sky in this case, or if you're looking at a white wall. And they usually move as your eye moves because they're basically free to float inside the eye. So floaters are usually caused by changes in the vitreous, the clear gel inside the eye. So the main cause for floaters is a normal aging process. So as we age, the vitreous basically becomes more liquid and shrinks, forming tiny clumps or strands that cast shadows on the retina. Floaters can also be due to a posterior vitreous detachment called PVD. So basically, the gel pulls away from the retina, as a part of a normal process, which can create sudden new floaters. And this is more common after the age of 50. Floaters can also be due to a bleeding inside the eye, and this is more common in diabetic patients when you can have a bleed from the vessels in the back of the eye. Or it could be due to an inflammation in the eye called uveitis, where floaters are due to the inflammatory cells in the vitreous cavity. But usually this inflammation is associated with redness, pain, or light sensitivity. So floaters are usually harmless. As we say, they are part of a normal process. However, you should seek immediate attention when you get a sudden shower of floaters or if floaters are associated with flashes of light or with sudden loss of vision. In fact, floaters are sometimes associated with flashes of light, also called photopsia, which are brief flickers, sparks, or shimmering lights that usually appear in your vision without an external light source. They often occur in the side of your vision, so in the periphery of the vision, and may be more noticeable in the dark. So the floaters are more noticeable in the brightness, whereas flashes of light are usually more noticeable in the dark. So the main causes for floaters are, again, the posterior vitreous detachment. So when the gel shrinks with age, it can tug on the retina. So this mechanical pulling basically stimulates the retina and causes flashes of light. Or they can be due to more serious things such as retinal tears or a retinal detachment. But sometimes flashes of light can also be associated with migraine. Visual migraines can cause flashing zigzags or shimmering lights or sort of geometric patterns that usually last for 15 to 30 minutes and may or may not be followed by headaches. When you get flashes of light, it's very, very important to seek urgent attention, at least within 24 to 48 hours, because if it's a retinal tear, that can be treated very easily by doing a laser that seals the retinal tear. But if you ignore a retinal tear, for example, then the retinal tear can lead to a retinal detachment, which is a sight-threatening condition. An even more serious symptoms is a curtain-like shadow. So as you can see in this image, you have on the left-hand side a normal vision, whereas on the right-hand side you have a sort of a black curtain in the top left of the visual field. So a curtain-like shadow is usually a sort of sensation that a dark shade or a veil is moving across part of your vision. It usually starts from the side, top, bottom, or edge, and gradually spreads inwards. So it starts from one side and then becomes bigger and bigger. Unlike floaters, it doesn't move with your eyes movement, but it stays in the same area and may worsen over time. So it's a fixed shadow that you can't see through. It usually means that part of the retina is not working properly and is considered very, very serious. So the most common cause for a curtain-like shadow is a retinal detachment, which is the most and serious, or it could be due to a bleeding inside the eye, again, it's called vitreous hemorrhage, or it could be due to a vascular blockage in the back of the eye, or sometimes if the shadow affects the same side of both eyes, it may be related to a brain-related issue such as a stroke. It's very important that if you get a shadow, you seek urgent attention, same day, immediately. You have to go to the eye emergency immediately because that's a sight-threatening condition. So far we have talked about symptoms that usually affect the peripheral part of the visual field, such as floaters, flashes of light, or a shadow. However, there are some conditions that can affect the macula, which is the central part of the retina, responsible for the most detailed and precise vision. This can cause specific symptoms, in particular two symptoms. The first one is distortion, also called metamorphopsia. As you can see in the image, you have a normal image on the left and a distorted image on the right. A distortion is the perception that straight lines appear wavy, bent, or distorted, or that objects look mishappen. And it usually affects the central vision. The second symptom is called central scotoma, which is basically a dark or blank spot in the center of the vision while the peripheral vision remains intact. This can make reading or recognizing faces very, very difficult. So the two main differences between metamorphopsia and central scotoma is that the metamorphopsia, the lines are distorted but visible, whereas in the central scotoma, the central vision is missing or dark. These two symptoms basically share the same causes, which are macular diseases. The first and most common in the population age over 50 is the age-related macular degeneration. Many of you may have already heard of it, and it's basically a sort of a wear and tear of the eye, which is very, very common in the population age over 50, or it could be due to a macular edema, basically a swelling in the back of the eye. This is very typical of, again, diabetic patients or in patients with very high blood pressure, or it could be also due to a hole forming at the macula. It can also be due to an epiretinal membrane, which is, again, it's an age-related process. It's a sort of a scar tissue forming on the surface of the macula, which can contract and distorts the normal anatomy of the eye. Or in case of a young patient, that can be due to a central serous chororetinopathy, which is a swelling in the back of the eye, usually related to stress or prolonged use of steroids, even inhalers for asthma. When you have one of those two symptoms, you have to seek medical attention within a few days, not in 24 hours, but within 3 or 5 days. And that's very, very important, because needs to be any of these conditions needs to be treated promptly. A very useful tool then any of you can use at home is called Amsler grid. So basically, the Amsler grid is a chart made of horizontal and vertical lines, which can give you an idea if the lines are missing or are looking distorted. So I always suggest our patients after the age of 50 to use the Amsler grid once a week. The test needs to be done with one eye at a time. So cover one eye first and then the other eye, and see how the straight lines appear. If they start appearing distorted, or if you start experiencing a central dark spot, you need to seek medical attention very quickly. So just to recapitulate, who is at high risk of developing retinal problems? So usually people aged over 50, especially for macular degeneration, or very short-sighted individuals. Most of the retinal tears of the retinal detachments happen in very short-sighted eyes, or people with diabetes or with other cardiovascular diseases such as high blood pressure, or patients who've undergone eye surgery, for example, cataract surgery, or previous eye trauma, or a patient with family history for retinal detachment or for macular degeneration. So when to seek immediate care? If you get a sudden increase in floaters, showers of floaters, flashes of lights, or if you have a curtain or a shadow in the vision, or in case of sudden loss of vision or sudden distortion. Thank you.
That was great, Dr. Macchi. Some really good advice there. We actually have a number of questions in, so we're going to take those. So the first question, why do optometrists miss peripheral retina tears? Surely this is bread and butter work that would ensure better quality of eye care before more serious PVDs occur.
That's a very understandable question, especially if you've experienced a delayed diagnosis yourself. To be honest, optometrists are usually quite good at detecting retinal tears. However, peripheral retinal tears can unfortunately be very difficult to detect, even for experienced optometrists. And this is not usually due to a lack of knowledge or care. There are a few important reasons for that. The first reason is because the far periphery of the retina is really hard to see. So the retina is a very, very thin layer that extends a long way towards the edges of the eye. Even with dilation, the extreme periphery where the retina tears are most likely to happen, the very far periphery can be very challenging to visualize fully without specialized techniques like, for example, scleral indentation, which can be performed only by eye doctors, even better if they are retinal specialists. The second reason is the equipment limitations. A standard slit lamp exams and non-contact lenses allow to good views only of a part of the retina, where very anterior tears can sometimes be outside the field of view. And also because tears can develop very, very rapidly. The posterior view detachment can evolve very quickly over hours or days. So sometimes a patient may have a normal examination at the opticians, but then can develop the tear 2 or 3 days after the examination. So it's very, very tricky. So that's the reason why if you experience flashes of lights or increasing floaters or a curtain-like shadow, it's always better to be checked by an eye specialist.
Okay. Okay, thank you, Dr. Macchi.
Yeah.
Another question. I have a lot of floaters. I visited my optician who told me they are normal and that I would eventually get used to them. However, they are interfering with my daily activities. Is there anything that can be done about them?
Okay. Thank you for the question. This is a very common question I get asked almost every day. As your optician correctly explained, floaters are usually part of a normal aging process. In most cases, they are harmless and they are not considered a threat to vision. It is also true that the brain usually adapts to them, and most people learn to live with floaters without significant difficulty. However, in some cases, they can become very bothersome and can start interfere with daily activities. When this happens, there are basically two treatment options. The first option is a laser procedure. It's called laser vitreolysis, in which basically the floaters are vaporized by the energy of the laser. Usually, this treatment is recommended for patients with a single large floater, which can be broken into smaller and less visible fragments. For patients with numerous floaters, the more suitable option may be a surgical procedure called vitrectomy, which is a keyhole procedure in which basically the vitreous gel is completely removed from the eye. Both these procedures, although very, very safe, do carry some risks. So patients have to be aware of risks and benefits. So we have to be very careful in making the right decision with the patient.
Okay. Next question. On one occasion, I experienced a sudden loss of vision in my right eye. That lasted for a few seconds before returning to normal. I wasn't too concerned at the time, but should I have my eyes checked?
Oh, that's a very good question. Yes, you should get your eyes checked. A temporary loss of vision in one eye, it's what we call omorosis fugax, which is basically usually caused by a reduction in the blood flow, either to the retina or to the optic nerve. This usually happens where a small blood clot or a plaque travels from the artery in your neck up to the retinal circulation. Although the vision usually returns within minutes, the episode shouldn't be ignored because can be a warning sign of an impending stroke. Sometimes it's even considered a small stroke. So it's very, very important to get your eyes checked to look for signs of blocked or narrowed vessels in the retina, or identify some small clots in one of the small retinal arteries, or rule out other major causes for loss of vision. And also, your eye doctor will probably refer you to a cardiologist to get further workup, for example, for a cardiovascular risk factor, or sometimes it's very useful to get an ultrasound of the arteries in the neck, because usually the blood clot starts from the neck. And if there is an obstruction in the flow, you can be referred to a vascular surgeon who could perform a surgery to unblock the vessels in your neck. So it's really, really important, because it could be a very important warning sign of a bigger problem.
Okay, yeah, so definitely get those eyes checked. And then the final question, can I do anything to prevent another retinal tear?
That's another very good question. Unfortunately, there is nothing that can be done to prevent further retinal tears apart from getting your eyes checked regularly, because retinal tears usually happen suddenly. And when they happen, the only treatment is to do a laser on the tear to basically seal the tear, but you can't laser the entire retina in order to prevent further retinal tear. So it's really, really important, because if you had a retinal tear, of course, you are at higher risk of developing new tears. So I always tell my patient, if you had a tear, you need to get your eyes checked at least twice a year, every
Okay.
6 months maximum. So that's the best thing. Prevention is the best treatment.
Okay, some very good advice there. Thank you so much, Dr.
Thank you
Macchi.
very much.
I would like to thank our 4 speakers this evening, Mr. Stumpf, Mr. Higgins, Ms. Varga, and Dr. Macchi. We hope you found the talks this evening of benefit to you, with some key takeaways on the importance of early detection and prevention, tips for chronic eye condition management, and very important, when to seek care. A full recording will be available after tonight's event, and a survey will be sent to you via email, and we would love to hear your feedback. If you wish to learn more about our eye service in UPMC and how to access our consultants, please go to upmc.ie. Thank you to all who joined us this evening and participated in our Q&A. We have a further public event taking place on the 11th of March with our orthopaedic team in UPMC SSC, and it's an evening for hikers. So if of interest to you, please log in. So thank you to all, take care and have a good night.